afternoon, everybody. Thank you. I really mean that. Thanks so much for coming, because it's a big chunk of your day out. We've got about 80 people joining us online as well, so it's a really well attended annual members meeting. Warm welcome to the annual members meeting. I'm Sean Duggan, the chair of the trust, and it's a formal meeting, so we need to go through some formal business items, which won't take very long, and then we will get into some sharing about what we've been doing over the last year and reflections on the chief executive. We do have to go accounts and hear from our external auditor, but we do have also a couple of presentations that we can showcase some good stuff that we have done last year. The apologies, I have a number of apologies, and I don't tend to go through them from governors and staff members and non-executives. Declaration of interests, I haven't received any, so if there is a change from last year, I do need to ask you to approve the minutes of the last annual members meeting held on 24. I don't know whether that contribution was a yes, approve the meeting. So, yeah, we've got enough acknowledgements there. Can I just thank you for those that help do the marketplace, I think they're calling it, the showcasing the stuff that we've got out there, which I thought was really good, and so much interest from our stakeholders. I'm really grateful for our external stakeholders that are here as well, and our staff, so important to us. So, you know, again, to show my appreciation for that. Before I hand over to the chief exec, Jane Padmore, it would be today will be about reflecting on the last year and obviously going through some of our achievements, what we have done well, and some of the challenges of the last year. But it would be totally remiss of me not to mention the publication of the National Oversight Framework. We're calling it the NOF, which is published from NHS England, which is lead organisations, NHS Trust. We took a big hit. We are taking a big hit this year, and there's two reflections I want to add to that. One is that I know this organisation enough now as chair for 1.5 years that we will take this very seriously. We've clearly got a number of problems that we need to sort out, and we will, I know the exec and I know the leadership team, we will put a focus on that, a real focus. We'll back it up with energy and work and commitment, and also the sources, because we will have to do that. We want to do it anyway. And then the other thing is that we've had looked at the details, which we won't be going through today. You'll be glad to hear, but we've looked at the details, and the strategy that we've just approved for the next 5 years is a plan that correlates very much to the National Oversight Framework. We just need to stick to the strategy that we've all signed up to, and thank you for all those external partners that helped us with that, and then we will achieve what we need to achieve. We also know it's all very well me standing up there saying that as chair, it will only achieve successes in this organisation by the collective, all working together. And again, I appreciate all the work that the governors do in particular, because this is a meeting we have with our governors as well. Look, I'm going to pause there. One of the moments of last year, one of the elements that we included last year that was a real success was an executive question and answer session at the end. So those of you that are speaking, please help me with timing so we can give enough time for the questions at the end. Can I introduce Jane Padmore, our chief executive?
Hi everyone, it's nice to see so many people here today, and thank you for braving the weather. When I heard the downpour as I was walking downstairs, I thought, oh my goodness, I'm either going to have a room full of wet people or people aren't going to come. So thank you for coming, and thank you for those who have used our dryers. You're not here. Apologies, is that better? It's not on.
It's on. It's on. Coming out.
It is?
Yeah.
Is that loud enough? Oh. No, not here. Can we turn it up? No.
Right, we'll do on to it.
Okay. I think they're going to have a look at it. Hopefully you'll be able to hear me, and I'll speak as loud as I can, although I do have a sore throat today. And I've got to do the clicker too. Multitasking. So there you go. Right. So this year, not this year, last year. This is the annual members meeting that covers last year. So 24 to 25, April 24 to April 25, and it was a really big year for us. It was the year that we consulted on our strategy, our new strategy, and the year that we vision, values, and our ambitions. And this is a summary event. We had a launch event that was really well attended earlier in the year. And this coming year and the next 4 years are the year where we are going to be delivering that. And as Sean said, all the areas that we need to improve in are all in the objectives that are set through this strategy. So they're all in there with plans and trajectories. So our vision going forward is to deliver great care and improve outcomes together. And we've got new values of optimism, compassion, and accountability. And, you know, compassion is something I think we can all sign up to. We need to be kind with each other. We need to be understanding of each other, and we need to be able to think of things from other people's perspective. Accountability is about doing what we say we were doing. Where we aren't performing well, admitting it and putting in place things that hopefully will improve things, but also celebrating where we're doing things as well. So it's about really being honest about things and being transparent. And then optimism isn't a sort of an airy-fairy wishing that things will get better, but a true grounded optimism in this is the hope for the future. We have the plans and we're going to stay true to them and we're going to deliver them. And really believing that as an organisation with our 6,500 staff, everybody in their shoulders to the mill and really thinking about what is best for the population of Sussex, the people that we serve. The strategy was co-produced by over 3,000 people, with people with partners, and they have helped to shape those objectives. And I do find it really heartening that those objectives are things where we know we need to improve and where we can make traction. Right. Obviously, I've gone ahead of myself. So that for those of you who aren't so familiar with our services, we have over 300 clinical teams, and we service our services support about 29,000 people in the last year. Our staff continue to deliver services with compassion and kindness. And when I go out in services, I can't tell you how heartening it is that people talk about the challenges, talk about how difficult it is sometimes, but also talk about how committed they are to improving outcomes and working with patients and with carers and with service users and partners to really get the outcomes that matter for the people that we serve. We've had some really good successes over the last year. So our nurse vacancy rate has gone from 30% down to 15%. That's really significant and really significant for quality of care, because if we don't have the substantive workforce, then that impacts on quality. It means people aren't seeing the same people aren't seeing their regular clinicians. Our out of area placements has gone down from 31 to 2, so we've got 2 people out of the area at the moment. And our 52 people, the waits for cancer, and you'll hear about our cancer service a bit later. When we started the year, 105 people were waiting over 52 weeks for a service. At the end of the year, that was 5 people. That's a significant improvement that has only been delivered because of the work of our staff and the dedication of our staff, and really working to think about what is a priority and what matters for people. These are some of our statistics, which are also available on our website that you'll be able to see. So we're also a lead provider for provider collaborative. So I often think of us as having 2 arms. We've got our provider arm and we've got our provider collaborative arm. I'll come to this slide in a minute. I think I've jumped ahead of myself a bit there. But so if you think about the provider arm, that is where we provide services and we deliver those services. Our lead provider role is where we commission services and oversee services. And we are the lead provider for 3 NHS England collaboratives for the South West of England, with a budget of about 170 million. And that's for CAMS, Tier 4, that's inpatient CAMS services in Hampshire, Isle of Wight, Sussex, Kent and Medway. And for adult secure services in Kent, Surrey and Sussex, and adult eating disorders in Kent and Sussex. I have to read that because I get muddled up with which one's which sometimes. But so it's a different permutation, but it's around the southeast of England and 3 provider collaboratives. And the focus of that work is improving care for really complex people who have complex needs and are vulnerable, and making sure we use those public resources responsibly. Other key developments are we are building a new hospital in Bexhill, and that is part of eliminating dormitories and ensuring that people have ensuite bathrooms when they're in inpatient services. Dementia-friendly services that are therapeutic environments, and the whole design of Combe Valley has been co-produced with service users. So service users right in the middle of how we are thinking about how we do the layout of the wards, what it's like when you walk in, what's it like as you drive through, what does it mean when you go and get your medication, and what does it mean about privacy and dignity, the whole design. And this is due to be opened next year. And the build is well underway, having safe green areas for people to enjoy natural light, and also to reduce the reliance on out-of-area placements. We're also in the process of our new electronic patient record system, which is due to launch in November, and it will launch in November. And this is really exciting. I often think, if you think about digital, some people sort of, oh God, but actually this means really joined up care. It means that we will, primary care will be able to communicate well with us. It means that we will be able to collect data properly. It will streamline clinical services. It means we will be able to introduce electronic prescribing in a way that we haven't done before. It's a really significant, very large scale ambition, but we are going to deliver that, and that starts in November. It started already, but the launch is in November. So that was really great. And this slide, the one I've got up, I put up preempted too early, is about our staff survey. So we had a staff survey response rate of 45% last year, which is below the national average. And it was launched around the same time as we were doing some major transformations in our services. And our results were mixed. So we had 10 areas where we improved. We had 22 where we declined, and 68 where there were no changes at all. But what we've done is taken some decisive action, and not just an action plan that delivers against each of them. It's about cultural and systemic change. So thinking about a Leadership Plus programme. One of the things that came out was really positively was the experience of a staff's line manager. That was a really positive, and people actually having an appraisal. That was a really positive in that, and really building on that so that we can learn from that. We're doing, we've invested in equality and diversity and inclusion. We have 23 freedom to speak up guardians, so people hopefully feel safer to speak up when they're worried or when things aren't right. We're doing active bystander training, wellbeing activities and webinars. And in the future, we're focusing on leadership development, cultural intelligence, just restorative culture, and continuous quality improvement. So that you've been outside in our lobby, this is going to be an innovation space and an area for people to come and really innovate and think about continuous quality improvement that is driven by data, but also narrative. So we're not relying just on the stories people tell, or just on the narrative, or just on the data that is presented. But what does the data say, and what does that mean? How are we interpreting it and measuring how we're improving and getting into that continuous quality improvement cycle? These are some of our statistics that I went through, and some of the improvements we've seen over the last year. Our housing support offer has been really well received with partners, but also with our people who use our services, and we have reduced the number of bed days that were delayed due to pure housing problems from 600 bed days to 50 bed days. That is a really significant improvement, and it means that people are not in the wrong place and are not becoming institutionalised in a way that you do naturally if you're in hospital too long past where you need to be. It is not saying hospital is bad. It's saying hospital is bad if it's not the right place for you to be, and making sure people are in the right place to get the right care at the right time. We still have some way to go with some of the more complex housing needs, but we've really made significant inroads with that. So there's our I do apologise. I've done things out of order. My notes are in a different order to the slides, so apologies. So our breakthrough objectives, we did reasonably well. I'm pleased that we almost met all of our objectives. I'm disappointed we didn't meet two of them. And the two we didn't meet were around our outcome measures and really understanding that the treatment we deliver is effective. And part of that is to do with our recording. Our current electronic patient record system makes it very difficult to record that. Or did I just turn that off? No, record that and measure it. Our new electronic patient record system is going to make that much easier to record and understand not just whether or not something is effective, but whether it's effective for different populations, whether we need to tweak what we're doing for different populations and for different areas so that we're responsive to the needs of the population we serve. We don't just do a blanket one size fits all. But we did meet our objectives for all of the others around care planning and partnership working. We also met our objectives around finance. I'm not going to preempt Usman and his reports on finance, so I'm going to leave all the finance for him to speak to, otherwise you'll be hearing it twice. But we did do significant work. But what I do want to say on the finance is delivering our cost improvement plan last year was difficult, and it would be remiss of me to stand here and say we've achieved it and everything was rosy. It wasn't. It was very difficult, and it had an impact on people's lives. It had an impact on our staff's lives because their jobs were at risk. They were going through restructure. Whether we believe or not, whoever believes or not, the end result was where we needed to be. The process is difficult. When your job is at risk and there is uncertainty and there's change, it is difficult. And it is not something that I am adept to, but it is something we have had to go through and something we need to learn each year as we go through these processes. How can we do it better next year? There will be some things that happened in the last year in that consultation process and in the changes that we made that didn't land well and some that went well. We need to listen to our staff and we need to listen to our patients and our communities about what went well and what didn't went well. So when we go through these processes again, we do better each year. So our next 12 months objectives, I was really keen that, and the executive team were really keen and heartened to hear that when we heard from people about what really mattered, it was about the quality of our services. And so our first three are about delivering consistently high quality care. And the first, which is very apt today because it is World Suicide Prevention Day today. I'm speaking at an event tonight around suicide prevention. Our first is, what is the most tragic end result of some people that come to our service, and that is death through suicide. We decided as a trust to be bold and not just do it about patients who are open to our service, but to look at the whole population of Sussex and set an ambition of reducing the number of deaths through suicide for the whole of Sussex, because we are a part of the system and what we do matters for the whole system, not just to the people that come through our services. We also want to reduce our length of stay. Length of stay is one of the areas we did not perform well on our national oversight framework, and you will see it is our second objective here. We are one of the outlying trusts, and our performance around length of stay on our inpatient adult wards is long, partly because of our clinically ready for discharge data, but for multiple reasons. It's something we really do need to get a handle of this year and move forward. So that is our second. And then the third is about waiting times. This is something that really matters to people. As you'd understand, you know, I'm waiting, my son's waiting for some treatment at the hospital at the moment. I feel like every day I'm checking to see if the appointments come through. I know what it's like to wait for an appointment. It's frustrating. And each day you don't get an appointment, you get that sense of disappointment. And how long am I going to have to wait? So we are really wanting to ensure 95% of our adults are waiting for a bed, are getting into hospital within the time frame that they need to. So really look at, you know, when you're waiting for a bed in ED, it's not acceptable to be waiting longer than 12 hours. That's our third objective. And then to be a good partner, the key elements of our neighbourhood mental health service, mental health teams. Hopefully you saw the standout there with the lovely cakes, with the logo on. We're developing our integrated neighbourhood mental health teams. This is very in line with the 10-year plan of hospital to community, but really thinking about what does that mean for patients? What does it mean for the population we serve to be treated near their home, in their community, and avoiding hospital when it is not necessary, and really working with primary care for the best results. And we've started those, and we're having some really positive feedback, particularly from primary care and from patients, about what had the difference these integrated neighbourhood mental health teams made. Then you will know that physical health checks are really important. If you've got a mental health problem or a learning disability, your mortality rates are very different to the rest of the population. And it is the leader report came out, I think, last week or the week before, I can't remember, which is the learning from deaths report for people with learning disability and autism. There is an unacceptable difference in mortality for the people we serve. And so we've made that a priority, that making sure people get their physical health checks and we really attend to their physical health care needs as well as their mental health. And you'll see the others we've got: being an employer of choice, so thinking about participation, EDI, improving every day, that is about continuous quality improvement, and being sustainable, that's about the money but also about environmental sustainability. So I'm looking forward to the year ahead. It is a period of huge change for us, and there's no denying it's a period of change for us. It's a period of change for the NHS as a whole, and you can't look at the news without something about the NHS coming up. But also what is called the public opinion survey of the NHS has been really poor. Public opinion of the NHS is really low. And we all have in SPFT a part to play in improving how people see us. And that's about us being public servants and really thinking about how we attend to what the public want from us. So, but that is going to mean change. That is going to mean doing something different. It means also changes about improving quality. So continuously questioning our data, listening to stories about our services, both the good and the difficult. We can learn from the good. So when I went to Worthing Integrated Neighbourhood Mental Health Team recently and heard some feedback from a GP, I was like, this is brilliant. And when I went to another Integrated Neighbourhood Team, I was like, why don't you go to speak to Worthing? They're a bit, they started before you. We can learn from each other, learn from the positive as well as the difficult the difficult stories. And then our focus in the future is to make sure we deliver organisational strategy. That's being accountable, delivering what we say we were going to deliver, making sure that we actually constantly look at what we say we were doing and making sure we're delivering, and not waiting to the end of the year going, whoops, we haven't delivered that. But 6 months in, we're on trajectory, we need to change what we're doing in order to deliver it. And as a whole board, we're committed to doing that. So that, I think, is me. So I'm going to be handing over to Anna. Yes. So hello to you. Thank you, everybody.
Everybody, my name's Anna Moriarty. My role is Associate Clinical Director in the CAM Services, Child and Adolescent Mental Health Services in SPFT.
Hi, and I'm Nina Marshall. I'm the Programme Director for the Hampshire, Isle of Wight, Kent and Medway and Sussex CAMS Provider Collaborative. That's quite a mouthful. I cover the Sussex and Kent part of the patch.
So we're really pleased to be here today to share an update on the work that we're doing in the CAM Services, Community CAM Services and SPFT, and also the work that the Provider Collaborative is doing within the child mental health space. I'll talk briefly about the context, but not for too long, but just to acknowledge that nationally we know that the demand for children and young people's mental health services have continued to increase over time. And we know that there's been a shift in terms of the needs of young people as well. We're seeing that, we're hearing that nationally. Locally in Sussex, we know that our services have grown quite differently. So there's quite a bit of variation in how our services are provided. So what a child in Chichester receives in terms of their local mental health team might be different to what a child receives currently in Hastings, for example. So we really want to seek to address that in terms of a consistent approach to mental health in Sussex. We also know that the variation, while that can be really great in meeting local need, that there is that inequity, and also we know that broadly there are minoritized groups that are underrepresented within our services, and we really seek to address that through our transformation. So what are we doing to address all of the challenges that we face? The starting point for us last year was really talking to young people and families. So we've started a 2-year transformation programme, and we really wanted to hear, first of all, from young people, families and parents and carers and our staff group more around the challenges that they're facing. So this slide sort of just really is a visual that represents some of those themes. We couldn't get everything into it, but really just to highlight that young people were not only talking about the challenges around waiting and access, but also really what came through really strongly was young people really wanted to be part of the decision making around their care. They really wanted to have agency in the decisions, and they wanted to be seen as a whole person, so that all the services are working together to meet their needs. And that means all of our partner agencies as well. So the new model of care that we're designing currently for CAMHS services in Sussex is based upon the feedback that we've gathered, and that's over an extensive period of time, but also the revisiting the research evidence, the best available evidence in terms of what works best for children and young people who experience a range of difficulties, such as anxiety, depression, OCD. We've gone back to have a look at that. We've spoken to other sites nationally and looked at how other CAMHS services are working. And through that work, we're really engaging with our staff groups as well, just to really ensure that we're listening to and involving and co-producing the new model. We're also delivering this within the context of a framework called Thrive, which you'll see there is a kind of colourful picture. I won't talk too much about Thrive, but you'll hear some of our partners talking about it too, because we've all been signing up to really thinking about shared language around mental health. And our services sit more within the getting more help and getting risk support quadrants to Thrive, but it's so important that we work together with all of those who are supporting positive emotional wellbeing. So the full rollout is planned for 2026. And we really aim to provide what works best and provide timely and fair access. So we want to ensure that our services are accessible. So where we're working with children with moderate to severe mental health difficulties, that if they also have a diagnosis, for example, of autism, that our services are accessible to them and we're still able to achieve the outcomes that we would like to. We also commit to tracking goals and progress with young people through this change. So we really want our work to be outcome informed. So agreeing early in treatment, what are we working on? How will we know when we've achieved it? And that links to what Jane was talking about earlier. And we hope the EPR will help us with that. And that means that the majority of young people do not need to stay in our services throughout their childhood or adolescence, and actually that their planned treatment can come to an end and they can receive support within the community.
So I'm going to talk a little bit about Provider Collaborative. So we are focusing on the CAMHS Provider Collaborative today, but as Jane mentioned, there are other Provider Collaboratives. And Provider Collaboratives were introduced around about 2020 as a way of commissioning for specialist inpatient services with a focus on keeping people as close to home as possible, supporting people in the community by offering alternatives to admission and caring for people in the least restrictive of environments, and spending as little time in the hospital as possible. So this is our vision and our mission of the Provider Collaborative, but central to the Provider Collaborative is the voice of service users, families and carers, and they're at the heart of our decision making. So we will come on to that in a couple of slides. So the first slide we have is about the services that we currently commission or will be commissioning in the near future in Sussex. We do have other services across the footprint, and Sussex Children will access some of those. But to go through the services that we do have, we have Chalk Hill, which is our 12-bed inpatient unit in Haywards Heath, and we were awarded monies by NHSE to improve environmental areas, including sensory spaces. We have Coast, which we'll come on to in a slide also, and we have Springtide, which is our 10-space day hospital for children with eating disorders. We also have our family ambassador service, which is a really unique role, and that's for those for supporting parents and carers of young people who are in hospital or other provided collaborative services. The people in these roles have lived experience themselves. And we also have the transition service starting early next year, and we have the intensive support team. So to come on to the COAST team.
So COAST is the Crisis Outreach Acute Support Team, and COAST launched in April of this year, so very recently. We're very excited to be able to give you an update on COAST. We continue to provide a crisis service as we did before with COAST, so we provide mental health assessments to children across Sussex who are in crisis and targeted support, but actually COAST has a new intensive home treatment arm, which is an option for an alternative to admission. So for young people who are eligible for going into hospital when their mental health needs are acute and that's thought to be the best option, there's another option as well to receive that treatment at home where that's safe. Another role of COAST that's been really important, and we've seen some great outcomes, is in terms of supporting earlier discharge and supported discharge home. And young people have already experienced reduced lengths of stay in hospital and been supported. So the COAST team is working really closely with the Tier 4 inpatient units. The service has been co-produced, designed with young people. So the treatment plans, they're based on, again, as I spoke about earlier, what we know works best in terms of the evidence base or getting young people ready for that treatment in the community. But actually also young people have helped us to develop kind of the plans around how we deliver those therapeutic interventions, how we work with their families and help build confidence within families to manage difficulties at home. So the real benefits of COAST are remaining closer to family, friends, school, pets. Support can be tailored, support can take into account other needs, and parents, carers and families can feel involved in care. And where possible, it's the least restrictive approach. So as mentioned, the service has been co-produced with young people, and we continue to have that input. So we have a regular expert by experience forum now, which meets, and we have a parent carer group, and we've received lots of feedback already that's been really positive around that. So there's some examples there, and just to pull out a few of the sort of themes that come through. Young people have talked about this really addressing the gap between inpatient and community care, and having that option of supported discharge, which feels really beneficial for young people as well. So we've got a short clip just now to play to you of one of our EVs being interviewed on BBC Radio Sussex in May. So we'll just play that now.
I think it's good to use people who have used the services themselves because they know how it is from a first-hand perspective. People who are now in a better place can then communicate with the professionals to improve outcomes for everybody. So I've had experience in inpatient and outpatient mental health services, and for about a year.
Promise I didn't click it. I just moved it. Will I be able to do it again, do you think, Helen?
Press down.
I think it's good to use people who have used the services themselves because they know how it is from a first-hand perspective. People who are now in a better place can then communicate with the professionals to improve outcomes for everybody. So I've had experience in inpatient and outpatient mental health services, and for about a year now I've been working with the Provider Collaborative and SPFT to input on lots of different things and services throughout, and COAST has been quite a big part of that. I've been joining a regular meeting with COAST to update as the service gets ready to launch and things, and really just to give input. Is quite good communication I have with the professionals. We all feel on the same level. I think it just feels quite rewarding on both sides because our negative experiences can be made into positive ones by improving future care.
So, as I mentioned earlier, that the voice of service users, families and carers at the heart of the decision making of the Provider Collaborative. The last two slides were put together by our experts by experience who work with us. So they've made these slides for us and they tell us what they do. So what they've been involved in, how they've supported, what they've co-produced, and their work is absolutely vital for the Provider Collaborative. They've also included some photos of their time and work within the Provider Collaborative for everybody. So it's a bit of a whistle-stop tour, but on the SPFT website, there is a Provider Collaborative page, so you can look us up. There's a bit more information on there. I think we're happy to take questions.
You've got one. It looks like you're about to launch into a question.
Me?
Yeah.
No.
Okay. Oh, yeah.
It's working.
Yes.
Simple, really. My daughter, when my grandson was 3, wasn't speaking too well, took him in she was in town centre, and had a caravan run by social services. She took him in and said, I'm a bit worried about him. Within 2 weeks, he had a provisional diagnosis of autism, and all of the relevant services have been set up. My question is, if they do it in Warwickshire, why can't they do it in Sussex?
It's a big question, that one, around neurodiversity, isn't it? We haven't got into the detail around our assessment pathway today, but it's a really good question. But I know that, well, it sounds like Warwickshire have got things we could learn from, so definitely look at that. But actually, nationally, we know that the waits for neurodevelopmental assessment are much longer than we would like. I think we all feel very dissatisfied with the waits. So within SPFT, we're part of the sort of NHS Sussex-led piece of work that's currently underway to look at our assessment pathways, and colleagues are really involved in the adult part of that, and that's also for children and young people. And we really seek to review and look at the way that we're able to offer the assessments in a timely way. So that's working with our partners in education as well, and social care, and the whole system together, really. We can't do that piece of work on our own, but we recognise we have a really important role in that.
And Oliver, our Chief Medical Officer, is working with partners across Sussex to try and be more responsive and to bring down the waiting time to get quicker access. The answer is very complicated. It might look simple in Warwickshire, but they're quite complicated. But you're leading a model to model, to speed up the access. Okay. Well, look, we need to move on. Thank you so much, very much indeed. And, we're now going to ask Oliver, our Chief Medical Officer, and Rob, who is the Managing Director, to talk to us about neighbourhood mental health teams.
Sure. Thank you, everybody. So, as Sean says, I'm Oliver Dale. I'm the Chief Medical Officer. I'm also a consultant psychiatrist, and I work in the community in Arran, what is currently the ATS, and will soon be the neighbourhood mental health team. So this is really important for me. I'm going to hand over to Rob, though, to introduce himself as well first.
Hi everyone, my name is Robert Schwansley. I'm the Managing Director for West Sussex Division in the Trust. I'm here not to represent the division, but just to tell you the story about neighbourhood teams across the Trust.
Thank you. I should also say I'm using these earbuds as hearing aids because I'm hard of hearing, so just in case you're wondering why I have them in there. So as I mentioned, this is a really important topic for me. I've worked as a consultant psychiatrist in the community for about 18 years, and I came to Sussex in 2023 specifically to work on the neighbourhood, the transformation programme for our community services. One of the drivers behind this was the long-term plan. If you cast your mind back to the investments that Theresa May started, and sitting alongside there were a number of different initiatives, in particular addressing issues within our adult community mental health services. The services at the time of the long-term plan being conceptualised were very complicated to navigate. Even for people working in them, they were confusing. And quite often, barriers were effectively formed for patients having access to our services. And unwittingly, they were really problematic for people getting access to the help they needed in a timely fashion. Quite often you would hear community services talking about patients not meeting the threshold for a service. And what this actually ended up meaning was a person wouldn't get the care they needed. And sometimes they would become more unwell, and then they would subsequently meet the criteria for the service. The heart of the neighbourhood mental health team is trying to address that issue in a number of ways. And I'm going to let Rob talk a bit more in detail about what we've done here, but I just want to mention a couple of principles. The first principle is to soften the idea of the primary and secondary care split, so that actually the expertise of secondary care is available to primary care, and the flexibility of primary care is available to secondary care. And the other thing that is driving this also is a much more local neighbourhood approach with a far simpler services, so that effectively services are experienced as a more coherent whole. So the patients are not sent from one service to another. They have an assessment, and that assessment is their gateway to all the different interventions that are important to people and make life worth living. And so this is very much a psychosocial approach about providing people with different opportunities that they need to get on in life. So that's the sort of basic idea behind it. I mean, it sounds quite, I've made it possibly sound quite simple. It is incredibly complicated because we're talking about lots of different agencies coming together, lots of different services. And the work here has been conducted over a number of years by a large number of people. I must mention Penny Fenton and Martin Dominy in particular. So Penny is our clinical lead in SPFT, and Martin Dominy, who works for Southdown as well. And they've really been consistent drivers behind this. But I'm now going to hand over to my colleague Rob to take us through a bit more detail, if that's okay.
Thank you. Yes, hopefully a bit more detail. I'm not now just conscious of this time as well. So the neighbourhood mental health model in Sussex brings together the range of services that are on the list here. And I think the key principle for us is to create boundaryless service between the different functions that operate in each neighbourhood. Our approach is about creating a framework for each neighbourhood with those functions, but not necessarily describe what it means for the local population. We want each neighbourhood team to respond to the local population needs. And as Oliver said, we're looking at primary care services, at specialist care services, at our voluntary care sector services supporting patients in when they need mental health support. You may have heard about integrated community teams, and I know Jane also mentioned about the long-term plan and how the ICTs are developing with the 10-year plan moving from hospital to the community. And across Sussex, we're working with sister partners with our other NHS organisations and voluntary care sector and people we work with to create integrated community teams across Sussex. So this is a lovely map. And we're very lucky that our neighbourhood teams overlap the footprints of the integrated care teams, which means there won't be a separate integrated care team and a separate neighbourhood mental health team, which is really important, starting to merge together both physical and mental health needs and support of the patients. There's been quite a lot of work done already, and there's been quite a lot of achievements. And Oliver already mentioned Penny Fenton and Martin from the transformation programme. I also want to applaud our voluntary care sector patient partners who are key and instrumental in designing the neighbourhood mental health model, and our patients and carers who are also actively involved in developing the model and hopefully in future delivering the model. We have agreed the, as it says on the slide, universal model for the neighbourhood team. But I must stress this is more of a framework rather than the script or prescription what it needs to look like for each neighbourhood team and community. We have commitment from primary care to get engaged. We have support from voluntary sector and other 40 agencies. I'm not going to read the slides, but I really want to stress that has been co-produced and co-designed. and this is just the beginning of a journey. I always say this is evolution rather than revolution. And we have some lovely feedback and quotes from our primary care partners, our service managers, our voluntary sector partners. What's missing from here is what it means for me as a patient, what it means for me as a carer. And we'll make sure we have that case story for the next meeting as well. But we're absolutely committed to getting the feedback and making a difference to people we work with. It's been a journey, and it's been going on for the last few years. And as I say, it's an evolution, not revolution, and it will take some time. And I think the key learning point for us is about the bringing co-production, co-design to the heart of everything what we want to do, maintaining the energy, and really focusing on the cultural change, because it's a bringing range of different people, different stakeholders, different views, different challenges that we all have to face across our lives, both personally and professionally. So where are we going next? We have embedded the closer team working. We have every neighbourhood team's got a MDT meeting set up or on the way to set it up. We have a clear way of working for our neighbourhood teams. And in fact, this morning, we have approved our standard operating procedure, which again outlines how we want the teams to operate, but it's for individual team to make it live and real for them. We spoke earlier about our new electronic patient record, and that's being rolled out in November, even though the journey started many months ago as well. And we continue to engage with our service users and patients and their carers, and with the Health Watch to really get the feedback and evaluation. How does the model work for them? And I need to be here. Apologies. And I think that's just the questions.
A couple of questions. Yeah, please.
I'm a city councillor in Chichester, which is the lowest tier. I'm trying to understand. Thank you. What is the catchment of a neighbourhood and how it compares with community mental health teams of the past? Is that the big change, or is it the multidisciplinary sense? And how are you defining the catchment and breaking down the old barriers?
So the catchment area of individual teams is largely staying the same, except for in Brighton. But we are also, and we're quite fortunate because the integrated care teams, which Rob mentioned, so they are a system-wide initiative to bring physical health and mental health services together. Now, it's just fortunate that the footprints, the ICTs, are very similar to the footprints of our ATSs. So to answer your question, what we're trying to do is we're trying to bring the different services that already operate within those catchments together, so they are experienced as one service, to avoid duplication of services and assessments and convoluted and complicated referral pathways. So for West Sussex in particular, you've had established a service called Pathfinder for a number of years, and that was actually an exemplar site mentioned in the community mental health framework, which the Royal College of Surgeons was published almost a decade ago. And what we have effectively done is brought Pathfinder together with ATS to create the experience of a single service.
Wait, a couple of questions here. But the mic's coming. Yeah. Yeah. But yeah, and your name.
Sean behind me.
No, but you.
You first.
Okay, I'll go in.
Yeah.
I'm interested in where you're going to operate from. Are you operating from GPs or specialised units, hospitals? And do you have any plans to get closer to the general public?
That's an excellent question. So when I worked I worked at Hospital in Fulham before I came to work in Sussex, and that's exactly what we did. I was based in a GP surgery, and I was seeing patients with GPs or just on my own in GP surgery. So eventually, we want to see much more activity occurring in GP practices so that we will be closer to people where they live. We will still need to have our own base teams, but we're hoping that eventually those teams will come together, actually be held in single sites as well. I hope that answers your question.
May I follow up? It's getting closer to the public. If we could get to the stage where you were actually opening units in, say, shopping malls, where there is good footfall, bringing it to the public as opposed to the normal regime of you have to come to us.
Yeah.
So can you get closer to the public that way?
So we've certainly seen in other systems, you may have heard of the Recovery College or the Discovery College, which are effectively adult education interventions for people wanting to understand more about psychological difficulties and mental health problems. And quite often you see those based literally in shopping centres and so on. I think, GP practices are sometimes also in such mainstream areas as well. So I think we are agreed, but the issue is it will take an awful long time, and as Rob says, it's definitely an evolution, not a revolution.
Got to change the thinking, haven't you?
And I think actually the physicality does change.
And also, this is where our partners help us change, like working with the voluntary sector. They're in the public, they're within the public, and we're working with the voluntary sector. Great. So, yeah.
Can I just answer on that
Oh, yeah.
point? Before you, if you don't mind, it's kind of answering you. I live in Weymouth, and we have things called front rooms on our high street, and they're places where people can go if they need something, a cup of coffee and some support. But also they can, the people in the team can also pick them up and take them and get them some help that they might need from a professional. So I think it's a really well-made point.
Yes, it's harnessing who are doing this.
To the longitudinal perspective of it, I started as a consultant psychiatrist in Bolton 42 years ago, I'm afraid to admit. It's the first 7 years of my time I was involved in developing the first community mental health team in Bolton now, and the setting up of the Bedale Centre, which has now been open for 35 years. At that point, you had a single team, but as time has gone on, community mental health has become more and more divided into different areas of expertise. You've got access and which due to recovery and assertive outreach and so on. But what's happened there is that you have more and more splitting between the care provided by different teams. Now, what now seems to be happening is hopefully the best of both worlds, where you're getting back the continuity of care that was lost with all the specialist teams. And you're also getting back more collaboration, while you've still got the gradual increase in specialist expertise, specialist clinical expertise in all the different teams and different differently trained clinicians. So hopefully we've got best of both worlds.
Couldn't agree more, and an awful lot of this is around consolidation of services, so we make it a far simpler landscape.
Okay, fantastic. Well, let's thank Oliver. Yeah. So now for the really exciting bits. Finance.
Everyone hear me? Yes. Good afternoon, everyone. For those who don't know me, I'm Chief Financial Officer. So I'm just going to take you through a few slides that set out in sort of very high level the deep what our financial position for last year was. For those of you who are interested, there is a very big pack on your tables and online for colleagues who are there. You will find all our annual reports and annual accounts there if you want to go through those, which I highly recommend because they're incredibly exciting. So a little bit about last year. So what we've really just done here is set out kind of where did all our money come from. how are we funded? Because it's one of the biggest questions I get. People ask me, so where does all our money come from? And to the point that James said at the start, I think what's really interesting here is if you look at the income for our clinical services, 356 million, that's the money we receive largely from our local commissioners to run ATSs, our core clinical services, crisis response. But we received 158 million from wider collaborative. That in effect flowed through the organisation that we were then responsible for the commissioning of to various other organisations. So I think it is something that we should always keep in our minds as an organisation. It's not just us as a provider, but it's us as a commission. You'll also see on there sort of education, training and research, other. I will just call out, because I often get questions on this, what's this additional pension contribution central funding line? I'm just going to say it's a technical line. When employer pension contributions increase nationally, NHS England funds those to all NHS organisations. There is a notional that will be then put into our accounts each year. In effect, money that comes in, you'll see on the next page. It's not something we necessarily control over. So £556 million of income. I will.
Yeah.
Having some technical problems. Bear with us. While the screen fixes itself, I'll do on the next page, it would have said we have £559 million of expenditure. So for the eagle-eyed amongst you, you would say, well, that means we had a loss. We actually did report a break-even position in terms of how we report to NHS England and how we are. We did have a technical impairment that generated this sort of technical loss, this accounting treatment. For the purposes of reporting to NHS or in terms of what used to be called control totals, we were break-even as an organisation. And what you've got set up there is, in effect, where did we spend all of the money? So as you can see, and I think one of the important things to keep in mind as we come on to the next section is how much of what we do goes on to people's pay. So the single biggest item when you strip out the provider health, the mental health collaborative, is pay for us. Something like 80% of our spend goes there. That means that when we are in a position where we have to make savings, we don't have lots of other spaces to go. Against that list of things that are set out there in terms of where else we might look, drugs and clinical supplies make up the sort of biggest item, premises costs, and then sort of what our capital charges, depreciation and amortization. So we absolutely always look for efficiencies in those areas, but ultimately the majority of what we spend is on. That is where we will always come up against a very difficult challenge when we are asked to make savings. So if I go to the next slide, I guess there are some of the, we call it key achievements, and that is, I guess it is an achievement, but it's in no way to take away from what Jane said at the start, that I don't underestimate how hard it was for the organisation, for all of the thousands of staff that work with us, to go through the process that got us to deliver this and to deliver our it was a absolutely trust-wide plan that we came up with, and it was a multidisciplinary, all parts of the organisation helping deliver this. It wasn't a finance plan, it wasn't done through finance. We sort of set the frameworks, we provide information analysis, and we try and support the delivery where we can. But I guess it really was a whole organisational effort. The single biggest thing that we did last year, and some bits that are here, are in effect our agency spend. We managed to reduce by £12.5 million. So year before we were roughly £35 million, and last year we reduced that by £12.5 million. We're going to have to do that, we're going to have to do similar numbers again this year in order to get within the caps that NHS have set. But I think it is worth sort of really taking a moment to think about 2 years ago when we were sort of starting that plan, that felt really impossible to achieve. I remember the conversations at the entire teams. So we will never be able to survive. It's not possible. And actually, we've managed to do that. And I think really importantly, we've not compromised any of our safer staffing ratios, staff all our wards safely, ensure people we need to do our role. But it was about how do we make it reduce the most. So, and 12.5 million was the overall number for agencies. Specifically, you can see there sort of what the agency reduction in medical was, and nursing, the rest of it being in other areas, whether it was corporate, non-clinical, nursing agencies. And we clearly also went through quite a difficult process. Some of you will be aware, I know all of staff internally were involved in the corporate services review, and also delivered a very significant saving for us as trust, £1.76 million. And that was pretty much, along with the estate saving, delivered the full 20% reduction of the cost that we said we were going to try and do. But again, not to take away from how difficult and challenging that has been, colleagues, and remains. I guess the big thing from a capital point of view, many of you, I know, will hopefully been to visit and see as it's been going up, is our new Coombe Valley Hospital in Bexhill. Work which work is still underway on, and hopefully we will be getting our hospital next year. That was the biggest element of our capital programme, is to sort of on the back of the erection norms, and that is itself on the back of successful work done at St. Raph's in the east and other areas within our organisation. We also continue to invest in our new digital infrastructure. I think it's fair to say that's been taken. There's been quite a lot of effort we've had to put into modernising the trust digital infrastructure, and the sort of main final component of that is going to happen about 60 working days when we go with our new EPR system. And sort of we've listed out there a few of the other things that have happened as well. So we converted one of our dementia wards into a adult age ward in Brighton, because that was in effect what demand profiles looked like. That was what we needed, and that has gone live earlier this year. So that was kind of a recap of last year and what we did, and I'm happy to take questions if people have them. I guess just very briefly, I will say we've also just set out. I think it's important to recognise the financial context. I imagine no one here is not aware of how challenging national whole government finances, and therefore the impact that clearly has on the health service. Having said that, I think the health service has received a reasonable set of money, and given the context, and therefore the message is very clear: we are going to have to live within the money we have. How do we use it effectively? How do we use it productively? How do we get the most value out of it so that we can continue to offer services that we want to our patients? I won't read through all of that because I can see the chair looking at me. But again, just I think for context, it's sort of where have we come from and what does this mean? In 2023, when we sort of started looking at this, we identified that we did have a very significant underlying. And the reasons for that sort of have been well trailed and sort of talked about, but I will say it didn't just materialise, it happened for good reasons. Through the preceding years, the organisation, like many, had been given lots of non-recurrent funding, and rightly the organisation tried to use that money to expand its services, which it did, to offer new services that were not, services that didn't provide. But the funding environment has clearly changed. And so a lot of that funding has gone, it wasn't recurrent, and we are going to have to continue to live in a constrained environment. So we delivered £25 million last year. We're having to do 33.8 this year, which is more than we had hoped needed to, but inflationary pressures, pay awards, all of those kind of things, they all add up. And those are the things that we have to continue to recognise will continue as we go into sort of next year. And this is just a summary of kind of what does 25-26 programme look like. But join us again next year and we'll find out how we did on it. Right, I think I'm going to hand over to Brian now. External.
Yeah.
Oh, do you want me to take questions first?
Oh, if there's
Anyone got any questions? Happy to take some. Okay.
Afternoon, everyone. One slide from me in terms of what the external auditor does. It's a question you're never asked. But in effect, we report against 3 areas. First is the financial statements that you have in front of you. So we provide an opinion on the figures within financial statements. What we're trying to do is say whether or not those financial statements, the income and expenditure, the balance sheet, let's just talk through whether they are accurate and show a true fair view. So we have reported in respect to the year end of March 25 that they are, clean audit opinion, and that the accounts that Usman's just talked me through are a fair reflection of the activity over the course of the year. We're also, as NHS external auditors, required to comment and produce a report on the steps that you've taken to achieve value for money. So that's included within the external auditors report that's published on our website. And again, our responsibilities there are quite a commentary on that and to identify any significant weaknesses in relation to your arrangements for value for money. And we have not identified any significant weaknesses again in respect of the year end of March 2025. And lastly, we're required to provide an opinion as to whether or not the financial statements have been prepared in accordance with the all of the guidance from the Department of Health, which is generally wrapped up into the group accounting manual, and your accounts do comply with those, and they have been prepared in accordance with the NHS Act 2006. And lastly, to say in terms of the audit this year, the accounts were delivered and the audit was delivered in line with NHSE deadlines, which is bringing you back on track in respect of year end of 2025 to meet those deadlines. So that's probably the 3 key things. But again, I ask any questions if there are any.
No, thank you very much, Brian. Yeah, really good. Thanks very much indeed. It's great. Okay, lovely. The bit that we're going to talk about now is our governance, the role of our governance, and reflections from our lead governor as to what's happened. It's been a very busy year. There's Sarah Payne, who is our new lead governor, and Catherine Eastland is our vice lead governor, but she sent her apologies. But Sarah, thanks for joining us. Really, I think this session is just about your reflections of the last year, any highs and lows, and but I'm personally very grateful for you taking on the role of lead governor, and I think the relationship between my executives and the governor is improving very significantly. And I think it's largely the way that you're getting into your role. So I'm really, really grateful. Sarah.
Thank you, Sean. Yeah, I'm enjoying it. Indeed. So far. Should we? Are we going to go through these? Okay. So broadly, we've got our governors fall into 4 different categories. So we've got our appointed governors, staff governors, public governors, and service user governors. We've recently dropped the number of governors down from 33 down to 25. But we do still have some vacancies at the moment. With the appointed governors, we are looking for 3 governors, 1 in East Sussex, 1 in Brighton Hove, and 1 from voluntary partnership. Which is that going to be young?
That's what we're trying to say.
Young. Yeah. Okay. And then with the public governors, we're looking for someone to cover Brighton Hove. We've got all the other areas covered. And with the service user and care governors, again, Brighton Hove is carrying a vacancy. I think with the latter 2, we are going to have a by-election perhaps in 6 months. Is that correct? Sorry, I'm looking to your reassurance there. So still a few vacancies there, but we just had a recent election, so I've got a few new faces here in the room. So welcome again.
Any thoughts on? It's been a challenging year. It's going to be a further challenging year ahead. We have the governors' meetings. The executives and non-executives will say what we're doing about the quality and the finance, etc. And you pull over that. You are there to hold us to account. Any reflections on how we're doing? And please be honest. And in areas that you feel that we might need to improve on.
I think it's going well. I mean, we're in a bit of a transition at the moment. I know I bang on a lot about going from virtual back to in person, but I think definitely there's been an improvement in the relationship between the governors and the NEDs and the board as well. And I think it's a really big improvement meeting in person now. In terms of relationships, I really value being listened to and just the relationships you have with Jane and yourself. I and a couple of others have been involved in interviews with the new NEDs, and so it's been great to kind of be there from the beginning of their journey and to get to know them from there. So yeah, I've got high hopes for them.
You're not executive director, are still traumatised from that experience.
Not too high, we think. Just over it.
Yeah. Very good. So we'll continue that. Pardon? Formal slide.
Yeah.
Oh, God help us.
Yeah,
Yes,
I
yeah.
haven't used one of those before.
Switched.
Oh,
Yeah, achievements.
my turn.
Yeah.
So 24 to 25, we've appointed 2 non-exec directors who we've just spoken about. We've appointed a new lead and deputy lead governor, that's me and Catherine. We have had elections this year and elected 7 new governors, increasing the council composition by 20%. We've approved some constitutional changes which included increasing the voice of staff and young governors. We have council engagement in the annual plan and trust priorities for 25 to 26. I think that relates to a meeting we had in February. And then we are involved as stakeholders in the Coombe Valley Steering Group. I know Catherine's been very involved in that. And I don't know what the company's saying. Yeah, it's just Catherine.
I think it's just Catherine.
Yeah, okay. We have approved the chairs and NED's appraisal and the full fit and proper person test. Yeah. And yes, we can. This is ongoing, but we continue to provide consistent and effective observation of our board committees.
Good. Yeah. And which we're very grateful. It's a lot voluntary, and you do a lot for us. So that's excellent. I think that's all we need to cover. And yeah, Adam is our company secretary. What's your title at the moment?
Associate Director of Corporate Governance. Nabil, our company secretary, is in the room. I just wanted to touch on a couple of bits, just in terms of the priorities for the council. We had a really effective task and finish group around working on that relationship between the council and the board. And into 25-26, the council are working on these 4 areas. So one around being really clear around understanding the role and responsibilities of our governors and our non-exec directors, about building a membership strategy that supports our governors in representing their communities. And I'm going to talk a little bit more about our members. This is our annual members meeting, so it's really important to recognise what our members represent. Our third priority around maximising the opportunity for governors and NEDs to build a relationship with each other. And Sarah talked about the joint board and council meeting we had in February about our annual plan, but we've got other events such as our staff awards that's coming up in November, and a really good opportunity for our governors and our council to be involved in both not only the shortlisting and election, but also the presenting of those awards on that night. And then lastly, we set a priority earlier in the year around reducing the composition of the council, which Sarah touched on, which we now have a 25 strong council, and as I say, a few vacancies there, but I'm positive that we'll have most of those vacancies filled in the appointed category by October and in the by-election in January. So I'm excited for the year ahead. We have a requirement at the annual members meeting just to talk about our members. For those that don't know, we have just over 9,000 members in the organisation, many of them from our FT establishment back in 2008. Some of you may have joined by bumping into one of us at, I don't know, perhaps Pride after a few drinks, and we are filling the form, and then you forgot what it was, but you remember, and we continue to communicate with you. We've got most of our members are our staff. We've got just over 4,000 staff members, but what you can see here, we've got just over 2,000 service user members and about 2,000 public members as well, and that makes our membership foundation trust. Our members are structured in a range of ways. Those that just want to be informed so that they get just information as and when we're doing things. Those that want to be more involved in things like our experts by experience work, our working together groups, or in things like our establishments at the hospitals. And then those that really want to take a lead, and those that are really interested in becoming a governor, and we've got a good percentage there. Our members represent our community, and so naturally it's relatively representative of our Sussex demographics. But one of the things we've identified is we need to look at what is our members' database and think about how we strengthen the diversity of our members, and that brings me on to thinking about our membership plan. So we had a membership plan from 2020 to 2025, and with the launch of the new trust strategy for 25 to 2030, we are really looking now to reach out to our members, think about what does that plan need to look like, and what are those priorities that we want to set? How do those priorities support and underpin the work of the organisation? And so we'll be looking to engage with our members over the coming months to start getting feedback about how we establish our membership plan for 25 to 2030. I can't help but not touch on a couple of achievements. I'm hoping that members feel that we've increased our levels of engagement over the last year. The Trust produces a really engaging quarterly newsletter. We push that out to our members on a regular basis. But I also want to note that our work with our members isn't just about the work that we do in a corporate governance space, but it's also about the work that our engagement teams are doing out there working with services. So I've reflected some of our achievements here around our Triangle of Care accreditation. We have 250 experts by experience, people that are using services and working with us, as well as 70 peer support workers. And I think we're looking at the moment around how we improve that frequency of communication with members, and that's something I hope you'll join us on that journey over the 25-30 period, and as we establish that membership plan going forward. So I will pause there and hand over back to Sean.
Yeah, very good. Thanks. Really good. We'll see how the questions go. Jane, if you'd like to come up and join us with the executive team. Yeah.
Sean, there's a mic in the room and we may have some questions come online.
Have a think about what you'd like to ask. First thing, I think we'll I'll stand to the side and then perhaps I'll pass it and we you know Oliver, you've had Oliver, you know Jane, and you've done Usman. If I'm David, and excuse yourself.
Hi everyone, I'm the interim chief nurse.
Hi, Colin Hicks, the Deputy Chief Exec, Chief Strategy Officer.
I'm Dan, Chief Communications Officer.
John, Chief Operating Officer.
Good afternoon, Zoe Chalwin. I am the Deputy Chief People Officer.
Brilliant. Well, look, we've got to make use of this, haven't we? This only happens once a year. It's
Thing on question time.
Lining up for Interpol.
That's or question time.
Frederick.
Very good.
Frederick, do you want to ask a question? Would
you like to ask a question? No. Yeah. Well, you joined the executive team. So yeah, that's it. Lovely. Yeah. Anybody? A couple of things that what are you thinking? A couple of things that are on my mind. You were talking, Jane, earlier on about the staff, so how important it is to us, and we there was a mixed results. what are we doing? Please just, I mean, we need to say that Fulmy, our Chief People Officer in the Energy Centre, we do have very. What are we doing about the areas that we were a bit concerned about the staff survey last year? What are we doing to address that? Because we did talk about a plan with an opportunity here just to sort of tell us a little bit about the plan. I presume, Zoe, actually it would be a good place to start with you.
Thank you. And yes, absolutely. More than happy to start. I may well call on somebody else within the wider forum who's actually, I would say, mirroring what our plan looks like in practice. So we launched our Cultural OD programme in November last year, and Jane touched on some of the achievements already within this. That included things like our Leadership Plus programme, Active Bystander, Cultural Intelligence, and our plans for the future in relation to our Leadership Potential programme. What's critical for us now is to get out into our services, to engage with our people and to show that we're listening to their voices. I would like to bring in somebody who I think is mirroring that in practice and talking to his teams. And Rob, I don't know if you'd like to. Sorry for putting you on the spot. But Rob's MD of West Sussex is really bringing to the heart what I think staff engagement and the staff survey mean to us as a trust.
Thank you for putting me on the spot. I normally do that with my team. For me personally, staff survey is really important. It's just one of the tools that we can use to really gauge how the teams feel. What I really want to do with our operational services, but also corporate services, to make sure they see the staff survey as a tool to make difference for their local teams. Staff survey happens once a year. We need to be using it as the starting point for our staff engagement experience across the year. One particular objective that I think we all want to focus on is to increase our response rate, because if we increase the response rate, our results will be more meaningful. There will be better spread of views and really how the people feel, and then we can really make a difference. So that's the focus. And I think the specific things that we do in real life is to make it live and have that discussion on every service visit, on every team meeting, and about creating those opportunities for people to complete the staff survey, not make them do it, but really sell the benefit and give them the choice to take part in that.
Okay, is that it? Anybody else? Yeah.
I'll just add a couple of things to that. One is to say that the reason the staff survey is so important is because of the link between staff experience, engagement and patient outcomes. So that's why it's something that we're focusing on as a leadership team, in order to drive those response rates up, as Rob says. A couple of things I would say around that. One, we need to demonstrate to our staff that this is really important feedback that we listen to and act upon. So last year, a lot of our staff told us they'd had an appraisal, but they didn't find it a particularly useful or valuable process for them. So we're listening to that. We're changing the process. And secondly, it's not just about the staff survey, it's about what we do as an organisation. So we know there's loads of evidence that shows what makes a difference to staff experience is having a clear and meaningful role in a clear team with a manageable workload. And that really goes back to the heart of what we were hearing about earlier in terms of the CAMS transformation programme and neighbourhood mental health teams. So there's a lot we need to do. We are listening to our staff and we do need to get those response rates up.
The other thing I just wanted to add is it's really important to understand the staff survey is not just about looking at where there are things that we need to do better. I think you mentioned actually about the positive feedback that people made about their immediate line manager. So it's also about focusing and reinforcing success. And so what we knew is that a lot of people did not actually have a clearly identified line manager. This was particularly so in the medical workforce. I'm just going to use them as an example. When I took over my role, we had something like only 6 people appointed to clinical lead roles and line managing doctors out of 16. We've now got 15 out of 16 in place. And that means that most of our consultants have a much more clearly identified line manager. And it's those sorts of simple things actually which makes people's lives, working lives, much more enjoyable. They feel safe, they feel valued, etc. If you don't have a line manager, then that's a really significant issue to have to deal with.
That's great. While you've got the microphone on, got a couple of questions online, and one is about neurodiversity. Well, why don't we return to the point you mentioned earlier about the Warwickshire experience for your daughter? It is a priority for us. Do you want to sketch out what we're doing over there? Yeah, it'd be really helpful. Sorry.
So yeah, the question I think you made, the gentleman at the back, is really very much on our minds, and fundamentally what we've noticed over recent years is a much greater recognition of ADHD and autism and other neurodevelopmental issues, and this has meant that the service design that we had in place is just not fit for purpose anymore. And also the very understanding, our understanding of the nature of these difficulties has shifted considerably. And so as an executive and as a board, we recognise actually that neurodevelopmental issues are everybody's business, and they require a mainstream approach. And what I mean by that is colleagues in all professions, in all areas of health and social care, need to feel comfortable and confident in looking after people's diverse needs. So we've been working with the integrated care system to describe a model of actually what that will look like. And there's a lot more work to be done because it obviously is going to require some sort of funding. But the experience you described with Warwick, my hunch is that part of the reason why they were able to achieve that was because they had a more integrated and mainstream approach. And certainly in SCFT, one of the things, one of our partner organisations, one of the things they've been doing is looking at their paediatrics clinics to ensure that basically they can make a one-stop shop assessment, if you like, instead of people being referred to different waiting lists, etc. And it's those sorts of initiatives which will close the gap and improve people's experiences. But there's a lot of work to be done still, and a lot more negotiation with partners to make that work.
Great, lovely, thank you, Oliver. And another question is, we talked about the challenges and the objectives going forward. It's probably to start with you, Joe. What's the most challenging objective or couple of objectives that we will be working on over the next couple of years?
That's a really good question, and it depends what lens you're on. And I'm going to speak from my heart of what I think is our most challenging, and it links to the majority of our objectives, and that is delivering our strategy. So it's ensuring we deliver consistently high quality care. I think there's too much variation, and too many times where we're finding we are found wanting. And so it's the delivery of high quality care, which will then impact on suicide rates, outcomes and finances and everything else. So it's an overarching one, but it is that sort of getting the fundamentals right for everybody at every single point of access to our service. So that would be my first. If you're asking me about what is one of the really hot topics and things at the moment, it is probably around our flow of patients through our services. There are lots of teams along the way, and lots of entry points and exit points, and going into hospital and out of hospital is difficult. So thinking about, people waiting for over 12 hours in ED for a bed, and then at the other end, finding somewhere to live once they're ready for discharge. So that flow across the system that includes length of stay, and making sure that people are only in hospital when they really need to be in hospital and are back in their community where their loved ones are and their life is, as quickly as possible.
Anybody else from the David?
So I think just following on from Jane really there, I think the bit that we've talked about is around staff experience. But I think when we look at our clinical workforce, we need the very best, well-developed, well-trained workforce, right from that's our medical colleagues, but also our psychologists, our nursing staff.
the way the workforce looks now is very different from what it was 10 years ago. You know, we've got a lot more challenges around registered nurse recruitment and others. And what does that workforce look for our unregistered? And how are we growing our own? You know, we've had the commitment. SPFT was ahead of the game. We had the commitment to employ all the graduates, and that's fantastic. But also, what does that flow look like for the workforce? So the turnover has come down significantly, but also how are we taking people right from a very start of their career right through their careers and making sure those career pathways are in place right across all of the professions, really.
Thanks, David. One of the things Jane says to us a lot is to make sure that we are portfolio holders second, but board members first. So it feels really important that the money just doesn't sit with us. So I think we would all say that we can talk to the financial position. So whilst we've just talked about the waiting times for people to come into hospital, we've talked about the staff survey, we've talked about the quality of the services that we provide. It's important to stress that this is against a backdrop of a very significantly challenged financial position, not just with us, in the wider NHS and obviously our local authorities as well. So it's how we aspire to doing everything that we just described against a very difficult financial position. Now, I think we can do that, and it's going to require considerable effort. So to answer the question, what is our greatest challenge? It's hard to single out one particular one, but that is certainly, I think, something that cuts across all of our particular areas.
Great, lovely. But, yeah. Back to you, Sean. Yeah. We've just got one more question that's coming online. Thank you. It's I think probably Oliver and Jane. How many inpatient suicides in the last year, and how are we ensuring that our services are safe? It's a wide-ranging question, particularly the last one, but a really good one.
So it's more complicated than it might seem, because we have sadly had inpatient deaths on the board. And the one that most recently springs to my mind, it's unclear what the cause of death is, and we have to go through the coroner's inquest until that's determined. I think safety on our wards is always going to be a concern for us. I was thinking about some of the governance processes and quality, and I don't know, Jane, if you want to respond to that.
Safety on our wards. The first thing I'd say is there is always room for improvement, and we aren't there yet. And it speaks to the consistently high quality care that I'm talking about, that we need to get that right all the time. We're introducing the culture of care, which David would be able to speak to about what we're doing. But the other thing I'm doing is I have a concern, and the board has a concern, that we have quality assurance, and yet we have CQC coming in and finding out that we are still wanting. And that is not acceptable. Therefore, that tells me that something in our quality assurance isn't working. And so David, before he became our interim chief nursing officer, was coming in to do an independent review for us of quality assurance, and that is due at the end of this month, maybe the beginning of October, given the conversation we had today of competing priorities, but probably the first week in October, that is looking at our quality assurance, quality governance and quality oversight, so that we can really think about how we improve and how we make sure that we listen to the whispers in the wind before they become storms, that we find out where things aren't right quickly, and that we take action swiftly and decisively. And that means looking at the data, but listening to what people are saying as well, listening to the complaints, listening to the compliments, looking at restrictive practice data, looking at the incidents that are happening, so that we are really, really being responsive to what's happening on the wards. There is never going to be perfection, but what we can do is continually aspire to improve.
Yes, thank you, Jane. So I think the quality assurance is a really good tool. It helps us understand what our quality is, but it can't be the only thing. And there are new and different ways now of looking at some of this. And I think Colin's leading a great program around quality improvement, and that has to be the basis on what we're doing here. And we need to achieve a good balance between assurance and improvement. I think some of the tools, so when we talk about our suicide reduction plans, what's our quality improvement methodology around what we're doing here? We've got a new framework. I say new, it feels new, but it's not really. So those of us who've been around a while lived through the serious incident framework, which was great in its day, but it certainly had its day. And so we're now in a PSERF, a safety improvement methodology. And that's really needs transformational approach around, if we have a serious incident, it's not often an individual, it's a system or a process. And so we need to take a transformational approach to patient safety in driving up that and looking at what our data is telling us, linking it to improvement, to make sure that if we have got some changes in some of our metrics, that actually we've got some improvement programs associated with it. And it can be really transformative. So in my previous organisation, we had implementation of the Diamond framework, which was a QI approach. It drove incidents of restraint across clinical areas by 75%. And this is where the real improvement will be seen, is around QI methodology. So we have been focused on assurance, that's always going to have its place, but the improvement methodology and the improvement outcomes are where this will be really transformative.
That's a really good answer. And that what came across there was not only the knowledge base, but the passion, the heart that you got over. That's really good. Oh, so look, any final questions? If please, yes.
Well, in a sense, the elephant in the room today, and nobody's thanking Wes Streeting for it, is announcing those the league table, and listening to the everything you've told us today. It's very clear that that league table is not strong on quality of care and what is the patient experience. But I noticed you've talked about finance, staff survey, discharge times, which are all metrics. Can you tell me where you expect the partnership will be on the league table this time next year at the next meeting?
Yeah, that's good. It's good. And we expected that question. Jane expected that question, so I'm going to.
My goodness, I'm going to be held to this time next year. So we are very low, and it's unacceptable. I say from the beginning, there are different ways in which you can measure league tables and performance. It is what it is. There's no point in getting defensive about it. What the metrics they have picked are the metrics that we are not doing well in, and we've landed where we land. That's it. And so things can only get better. So things can only get better. I think that we're actually we're third in the country for patient experience on the CQC community acute metric that is measured, but the spread of that data is not, it is very limited, the range, so therefore it's not weighted very highly, but we actually came third in the country on that one. But whereas some of the other ones we didn't. I'm confident we will improve on length of stay, which is one of our metrics that we haven't done so well in. I'm also confident that we'll improve on our staff survey, but that's going to be tricky because we're going through some significant changes still, and it starts at the end of this month. So the lead into that isn't long and it's an annual survey. So whatever happens in September, October, November and staff survey, that is going to be it for the year. I think some of the other metrics I'm optimistic that we will improve. They are in our strategy and we have already highlighted them as areas we need to improve. So we already have robust plans. We haven't got them off. I thought, oh, blinking heck, we've really got to put a plan around this. We looked at it and went, oh, blinking heck, thank God we've already got a plan in place around this. So we're not starting from we're not from a starting standpoint. So I am confident we will improve. How far we'll improve when everybody else has improved, because the metrics are a league table. So you could improve by a certain number of incremental points. If everyone else does, we'll still be second bottom. You know, because that's the way it's measured. But I think my view is we've got to hold firm to our strategy and keep going, and think that we are here to serve the public. We are here to do the best for the public, and we need to stay firm in what our plan is. I'm going to hand over to Usman because he has performance. So he asked me, "Do you want me to answer this?" And so you might have something else to say.
On anything, Peter, I think we absolutely are committed to improving that. As Jane said, there are a whole range of metrics that could have been used, and on many of them we would have scored incredibly highly, and it would be having a different conversation. Having said that, we don't want to be defensive about it. The metrics that we did score low on are things that we are deeply concerned about. So we'll start saying the states. Those absolutely had already got plans in place, and will now just ensure we are doubling our efforts to make sure that those are delivered. I guess I didn't want to sort of end talking about money, but I guess it is impossible not to talk about it. And I guess that this is all in the context of, as John said, a really challenging financial environment. And I think I don't want to, I'm going into specifics. I guess it's really difficult to think that we're going to get through the next 3 or 4 months without also thinking about some of the really difficult changes we've made. So I guess that will coincide, again, as Jane said, with our staff survey results, and the timing of these things is never perfect, but I think it's more important that we continue to drive the change that we know we have, transformation that we have, get our services into a place where they're sustainable for the long term. But that does mean that there are going to be difficult and sometimes painful choices we have to make in the short term. And we had to do that last year. We're probably going to have to do that again. It's part of our plan, but that is how we get to long-term sustainability. I think the absolute key for our 5-year strategy, and I think that is what to remember about it, it's a 5-year program. We consulted, 2,000 people. It was 3,000 people. It was designed by our local community, by our staff, and so I think we have to stick to that. That's the plan, and I think it probably speaks to the fact that we had already identified some of the challenges. That 2 of the 3 sort of top priorities in there are exactly the 2 things that we know we have to improve.
And Dan wants to add to that.
I was going to say, I want to let us end by talking about the money, but that would be a bit unfair. What I would say with an assessment process like this is what matters most is how you respond. So if you perform really well, it's really important not to become complacent. If you perform less well, you need to focus on the areas for improvement that identifies. And I do think that comes back to our values around compassion, but also optimism, holding the hope about where we can improve and where we have achieved, but perhaps most importantly of all, that value of accountability, because this is all about the services we provide to patients, carers, families and our local communities.
I'm very grateful for the question.
Thank you for the answers.
Good, lovely. Well, look, any final one? If not,
Thank you. Can I say thank the exec team? I'm a non-exec director, and I just think it's really important to acknowledge how hard you work to drive the organisation, and you thank all of the other staff. So I just want to thank you while you all stood there so you can go red and all those different things. So thank you.
So if there's no any other business, then we'll close the meeting. Thank you very much.